Welcome to this Clinical Explainer. Today, we're zeroing in on one of modern medicine's most pressing and formidable threats, carbapenem-resistant enterobacterales, or CRE for short. My goal today is to give you a clean, professional, and comprehensive teaching lesson on exactly what makes these pathogens so dangerous and how we, as a medical community—
Okay, let's dive right in. Here's our clinical didactic roadmap for today. We're going to define the CRE threat, move into epidemiology and gene transfer, and then break down the classifications. After that, we'll look at detecting the pathogen, and finally, wrap up with treatment strategies.
Part 1. Defining the CRE threat and establishing our parameters.
Before we can ever hope to treat or contain a pathogen, we absolutely have to establish precise clinical parameters so we know exactly what we're dealing with. The CDC defines CRE as bacteria within the enterobacterales order that are resistant to at least one carbapenem. Think ertapenem, meropenem, dorpenem, or imipenem, or bacteria that produce a carbapenemase enzyme. Why does this matter so much? Well, carbapenems are usually our heavy hitters. They have a massive role in treating pathogens that already produce extended-spectrum beta-lactamases. So when resistance knocks out this class of drugs too, we hit a severe clinical roadblock.
To break this down a bit more, let's look at the clinically relevant families affected here. The primary one is the Enterobacteriaceae family, which includes the usual suspects you see in cultures all the time, like Escherichia and Klebsiella. Then we have the Morganellaceae family, which includes Proteus, Morganella, and Providentia. Now, here is a crucial clinical pearl. Morganellaceae are intrinsically resistant to imipenem. Because of that, to determine their CRE status in the lab, we only use ertapenem, meropenem, and doripenem.
Moving on to Part 2, epidemiology and gene transfer. Now that we have our definitions locked in, let's shift our focus to the broader public health impact. This number tells a pretty stark story: 12,000. That is the estimated number of CRE infections happening every single year in hospitalized patients in the United States alone. To put that into perspective, back in 2017, this resulted in an estimated 1,100 deaths and over $130 million in attributable healthcare costs. This isn't just a rare anomaly. It has immediate, highly consequential relevance for patient survival and our entire healthcare infrastructure.
Now, what's really fascinating here is how these pathogens actually achieve this resistance. In the US, about 70% of CRE isolates use non-carbapenemase mechanisms. That's usually something like upregulating a beta-lactamase gene combined with a porin mutation that literally acts like a locked door, physically stopping the antibiotic from entering the bacterium. But that other 30%? Those are the carbapenemase-producing isolates. These bacteria produce actual enzymes that actively hunt down and inactivate our antibiotics, and they are a massive focus for global containment efforts.
So how do these dangerous genes spread so effectively? It comes down to two mechanisms. Vertical transfer is pretty straightforward. It's just passed from a parent bacterial cell to its offspring during normal cell division. But horizontal transfer is where things get truly alarming. Think of a plasmid as a highly mobile survival instruction manual. Different bacteria, even entirely different species, can just pass these plasmids to one another when they're in close proximity. Thanks to this combination of vertical and horizontal transfer, resistance genes can spread like wildfire through bacteria-rich environments, like hospital settings or community sewage systems.
Which brings us to Part 3, classifications and the Ambler molecular classes. Let's look a bit deeper under the microscope and unpack the Ambler molecular classification system. This really helps us understand the specific microscopic mechanisms that make CRE so formidable. We have three main clinically important classes of carbapenemases here. Class A includes the KPC enzymes, which ride around on those highly transmissible plasmas we just talked about, and they're currently the most common type in the US. Next is Class B, the metallo-beta-lactamases, or MBLs. These are fascinating because they are zinc-dependent, and they are predominant in regions like India, Pakistan, and Eastern Europe. Finally, we have Class D, specifically the OXA48 types, which preferentially hydrolyze oxacillin, and are most common in Turkey and Mediterranean countries. Now, why does this geography matter for the patient right in front of you? Because international travel and medical tourism mean a patient returning from abroad can easily bring a highly resistant Class B or D pathogen directly into your local hospital network.
Let's pivot to Part 4, detecting the pathogen and laboratory methods.
Now that we understand how CRE acquires resistance, how do our laboratories actually detect it to give us actionable data? Standard susceptibility testing will tell you a bug is resistant, sure, but it can't definitively confirm the presence of a carbapenemase enzyme. For that, we rely on two distinct methods. Phenotypic tests use traditional culture techniques and reagents to sniff out the enzyme's characteristics. Genotypic tests, on the other hand, are absolute game changers. By using molecular methods like PCR, they can rapidly detect the specific genes themselves, like BLA-KPC or BLA-NDM, often directly from clinical specimens like blood culture bottles. Getting these specific rapid results drastically improves our ability to pivot away from broad empiric coverage and jump straight into targeted, life-saving therapies.
And that leads us to our final section, Part 5, Treatment Strategies and Antibiotic Selection.
This brings us to the culmination of our clinical explainer, how identifying that exact resistance enzyme dictates the life-saving antibiotics we choose. But before we instinctively reach for the newest, broadest drugs on the shelf, we always have to review standard susceptibilities. While it is certainly uncommon, if a CRE isolate actually remains susceptible to traditional standard-spectrum agents, we should absolutely utilize them. This includes fluoroquinolones, TMP-SMX, and aminoglycosides like plasmicin. There are also some really specific, highly relevant use cases here. For example, if you're dealing strictly with a simple urinary tract isolate, oral agents like nitrofurantoin or fosfomycin might still be highly effective options.
And this brilliantly illustrates exactly why understanding those enzyme classifications is so crucial for clinical practice. Your treatment has to be meticulously tailored to the specific carbapenems. For KPC isolates, we're looking at newer agents like ceftazidime avibactam, meropenem vaborbactam, or imipenem cilastatin relubactam. If it's an OXA48, ceftazidime avibactam is usually preferred. But look really closely at the NBLs, like NDM. These metallo-beta-lactamases confer resistance to almost all beta-lactam antibiotics. That level of extreme drug resistance makes targeted combination therapies, like pairing ceftazidime avibactam with astrionum, absolutely essential just to achieve a cure. Also, definitely note that the Cytophore cephalosporin cephalolicol serves as a solid alternative across all of these classes.
We conclude our lesson today with a pretty critical question for you to consider. As horizontal gene transfer accelerates the spread of these formidable enzymes across the globe, how will our antibiotic stewardship adapt to the extreme drug resistance of tomorrow? The biology of CRE is constantly evolving, which means our clinical vigilance, our laboratory techniques, and our treatment protocols have to evolve right alongside it. Thank you for joining this explainer.